ये आप लेकिन अल्फ्रेस्को का यूज कर रहे हो अभी तक? अब प्लीज मुझे बताओ, मैं अब इसको ऑन करूंगी तो वो चलने लग जाएगा? ये आप लेकिन अल्फ्रेस्को का यूज कर रहे हो अभी तक?
पोल्स
YouTube पे जाओ।
प्लीज मुझे बताओ, मैं अब इसको ऑन करूंगी तो वो चलने लग जाएगा? ये आप लेकिन अल्फ्रेस्को का यूज कर रहे हो?
पोल्स
YouTube पे जाओ।
ये रिपीट क्यों हो रहा है? प्लीज मुझे बताओ, मैं अब इसको ऑन करूंगी तो वो चलने लग जाएगा?
colorectal reporting format. Here again, 29% have chosen B as the option. Lymph node yield is usually high in left-sided and MSI low tumors. 44% say option C. 16% are saying option D. And 9% say it is option A. Question number 4. A 58-year-old female with a pancreatic mass, a gross image is given. What is your diagnosis on the gross morphology? Here, 53% have chosen mucinous cystic neoplasm, sir, while 29% say it is a serous cyst adenoma grossly. 7% have chosen chronic pancreatitis, and 9% say it's a pancreatic ductal adenoma. And moving to the last question, question number 5. In a pancreatic or duodenectomy specimen, which of the following is not a true margin? This is great. So almost 25% of the students have chosen each of the options. So almost everybody, it's ABCD 25, or approximately 25% each. So that was last of the pre-poll questions. So over to you, Dr. Rajiv.
Thank you, Prashant. Is my screen visible?
Yes, sir.
Am I audible?
Yes, sir.
Thank you. At the outset, I'd like to thank Dr. Gujral and Dr. Borges for giving me this opportunity to talk on this topic. And today I'm going to discuss about the normal histology and grossing of two important specimens of GI tract, that is colon and pancreas. So before I start, I have nothing to disclose. When it comes to the grossing, first everyone of us as a pathologist should be aware about the some fundamentals of the grossings. It includes first we have to orient the specimen in an anatomical position, take the adequate or proper measurements of the specimen as well as the lesion, identify the lesion. Wherever the surgeon has put his or her knife, they need to ink that area in order to assess the margins adequately, do appropriate sampling, and assess the margins. So these are the few basic fundamentals that applies to all the specimens. Just in a brief, I like to tell the audience that there are three types of margins which we usually sample. They are labeled as a shave margin, radial margin, and circumferential margins. So what is the difference between them? I try to correlate them with the normal fruit. So in the shave margin, it's like you can see that there is a peel of the outer surface is taken, and usually these shave margins are taken when the lesion or the tumor is away from the margin surface. And any tumor, if you see any tumor or any lesion at the margin, in the margin, irrespective of the site, it is regarded as positive. Next is the radial margin. Radial margin is usually taken when the lesion is close to the tumor. And the benefit of taking radial margin, you can actually microscopically measure how far is the tumor from the margin. And mostly the radial margins are taken commonly in the head, neck, and breast specimens. And third is the circumferential margin, which is very commonly sampled in case of the GI or specimens, especially esophagus and the rectal tumors. Here, the whole circumference or the periphery of the represents a margin. So these are the three common margins which need to sample. Coming back to the colon or the intestine, everyone is aware of it that it is small and large intestine. Just talking briefly about some basics. Although small and large intestine, it doesn't mean that it has anything related to its length. Although the small intestine is the largest part of the intestine and large and composed of three further subunits: grossly, duodenum, jejunum, and ileum, where the large intestine starts with the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and rectum. As we know, these are the tubular structures, and about the composition or how they are made up of. in the whole of the gastrointestinal tract, the more or less there is the same. All the layers are more or less same. It starts with the mucosa, followed by the submucosa, muscularis propria, and adventitial or subserosal fat, and at the periphery there is a lining called serosa. But there are subtle differences between the various parts of the intestine, especially you can see the small intestine and the large intestine. There are subtle differences which we should be knowing. Grossly, how do you identify? As I already mentioned, you should not try to make the gross diagnosis of large or small intestine based on either the length or the luminal diameter of the specimen. Large intestine has three very characteristic features which are present on the external surface. It's the Taenia coli, which are the Taenia coli. Usually there are three Taenia coli in the large intestine, and they are more clearly visible in the cecum, whereas in the sigmoid colon or the descending colon, you can't make it appreciate it better. And in when the rectum starts, you will not be able to appreciate the Taenia coli. Another two important things which are also there is the ostrations. They are the secular dilatation between the dilatation between the Taenia coli and appendices epiculatory, which are the fat-like projections on the external surface. Whereas, as compared to the small intestine, it has in order to increase the absorption or the absorption of the surface area, it has multiple these transverse like bands, which you can appreciate on the gross, which are called as plica circularis, and there are multiple villi which are seen on the microscopy. So these are the gross differences between the large and the small intestine. I'll just try to show you some of the histology of images of small and large intestine. I try to show it in the real as a digital slide. So if there are no network issue, we'll go to them. So this is the low magnification. On low magnification, you can appreciate, as I described during my presentation, there are various layers of intestine. This on the top or towards the luminal side, there is a mucosa. You can appreciate the uniform architecture of the mucosa. Then there is a submucosa, muscularis propria, and on the outer aspect there is a thin lining of serosa. So now I'll try to take you closely to each of them. So as you can, Prashant, is it vertical?
Yes, sir.
Yes, sir.
Full window, sir.
Yeah.
Window full.
Okay. So as you can see, this is the part of the mucosal aspect of the small intestine, and on the top there is a surface epithelium, which is, if you see closely, which is made of cuboidal to columnar cells, and many of you can appreciate there are even many cells with the intracytoplasmic mucin, which are called as a goblet cells. And on the surface of these the lining epithelium, which are called as enterocytes, there are presence of microvilli, which you can see as a thin carpet-like thing. Then next to it is a lamina propria. Lamina propria contain in the small intestine, as compared to the stomach, there are a lot of inflammatory cells, including lymphoplasmacytic cells there. In addition to these lymphoplasmacytic cells, there are some smooth muscle cells or fibroblast also can be appreciated over there, and lot of lymphatics and small tiny capillary size vessels, which helps in the absorption of the food properly. So these lymphoid follicles or lymphoid cells, they form the aggregates. If you go towards the ileum, and they appears as a Peyer's patch over there. Next layer, as I said, there is this thin layer of muscularis mucosa, which demarcates the boundary of boundary between the mucosa and submucosa, and below that there is this loose connective tissue where there is a lot of blood vessels or even the tiny nerves can be appreciated. And this is one of the area which I have highlighted. These are, you can see there are some ganglion cells which are present. So, so there are two neurovascular neurobundles which are, this is the Meissner's plexus, which is found in the submucosa, whereas in the muscularis propria you can also see such structures, that is a mesenteric plexus. Now these are the further layers of the small intestine. There is an inner circular and outer longitudinal layer, and towards the end is the serosal aspect. So this is the configuration or the histomorphology of the small intestine. I'll just show you some of the other areas which are highlighted. So these are in the mesenteric plexus, you can see these ganglion cells, and although not particularly in the small intestine, but they are very important to appreciate. It is very important to identify and appreciate ganglion cells for two reasons. One, if you are dealing with a malignancy, sometimes they can be misinterpreted as a malignant cells with the signet ring cell morphologies, and people can make the mistake. And another important thing, especially for the young children or for the diagnosis of Hirschsprung skin, we need to look these cells. Now I'll take you to the section of large intestine. So as you are seeing in the similar to the small intestine, the layers of the large intestine are also similar. The major difference which you can appreciate now well is in the mucosal glands. So here you can see that there are no tall villi and like things which is appreciated in the small intestine, and these glands also they are straight. Another thing, they ends at same level on the muscularis mucosae, and they are quite regular, and lamina propria in the normal colon has relatively less lymphoid cells, but they will be there. Another thing which I forget to tell you, on the small intestine, you can see the Paneth cells and M cells, which are usually lacking in the large intestine. So, and last, this is the cross section of an appendix, which I'm trying to show you here. And there is some equalates or fecal-like matter or towards the luminal aspect. And here you can appreciate there are multiple lymphoid aggregates which are almost forming like the follicles, which are present beneath the mucosae, muscular, and even they are going dipping down towards the submucosae. Otherwise, the lining epithelium also here is also tall columnar epithelium with the many goblet cells, and many times you also see some fibrosis in the lumen, and and it is also part of a normal process. So these are the basic histomorphology of intestine, including small intestine, large intestine, and in appendix. So with these basics about the normal anatomy and histology, I'll just move to the grossing of the colonic lesion, and my talk will be mainly focused on the neoplastic lesions, because the procedure or the protocols are more or less similar, but for the malignant lesions, pathologists plays a very important role in the management of the of colorectal cancer, especially the deciding the further post-surgical management, and giving the clinician some prognostic factors which decides the outcome of the patient. But there are some challenges are there which usually a pathologist faces while grossing these specimens. So we need to have a clear idea about how to proceed for the grossing and what are the why it is relevant for the clinicians. So as I said, the major impact or most important factor is the TNM, to provide an appropriate TNM staging for the colorectal carcinoma, because that is the major prognostic factor which decides the outcome of the therapy. And in addition to TNM, it is our moral responsibility to service handling the colorectal specimens to give information about non-TNM parameters, that is like dividing into core and non-core elements, which are also put in some of the core questions. The core elements are those data elements in the report as recommended by CAP or ICCR recommendations, which should be mandatorily present in the report. Non-core elements, they are the optional parameters, and you can skip them, but ideally it's better to have provide information for each of them. So the first thing, yeah.
Sorry to interrupt you. Dr. Burgess is asking, could you demonstrate Paneth cells and what is the value of noting them? You could go back to a small intestine slide.
So Paneth cells are important because for the normal gut microbiota they play an important role, and if there is a increase in the Paneth cells, especially noted in the inflammatory bowel disease or in a Crohn's disease, there is an increase in the Paneth cells, which gives a indirect indication. So is it visible?
Yes, it is clear now.
Yeah. So usually towards the base of the crypt, you can see there are some of the cells which have relatively more eosinophilic granular cytoplasm. So these are represents the Paneth cells, and as I said, relatively there you will not see them commonly in the large intestine, and it has a role for the controlling the microbiota of the intestine. I go back to the presentation.
Yes, sir. Thank you.
So, as I was talking about the core and non-core elements, and in which TNM is one of the most important thing, and one of the first question for the poll, which was put as a core element for the core element for the colorectal reporting, in which one of the option was T size was there, but we have to make a note of it in the GI tract. The tumor size is not a core data element. It is the depth of invasion or the level of invasion into the wall, which decides the T stage of the lesion, and second is the N is the number of node positive, and M we should put comment on the M stage as a pathologist only if we have a relevant biopsies or the specimens available to us. Otherwise, it is a clinical M stage, that is a metastatic stage. Few more some basic concepts. One is you have to very carefully evaluate the serosa, which is the outermost envelope or outermost layering of layer envelope of the GI tract, because it acts as a barrier to prevent the spread of the disease outside the confinement of the intestinal wall. Another important thing is, although it is presumed that serosa covers the intestinal tract, but there are some areas where it is lacking. Especially these areas are in the retroperitoneum and like in the cecum, ascending colon, descending colon. These are the small further area which are devoid of your serosal covering. And most important is in the rectum, where the large area of the rectum is without devoid of any covering. So it has two implications. One thing, so the surgeon, they need to put a knife over there and dissect that, cut out that area. It is not like a blunt dissection, and these all areas becomes a resection margin for the as a pathologist. Just a few brief concepts about the rectal tumors. We have to take a special care when we are dealing with the rectal tumors, because they are the outcomes of rectal adenocarcinomas even is different as compared to even the adenocarcinoma in the other sides, and there are certain concepts which we need to understand for that, why they are different. One thing is everyone of us as a pathologist should be aware about the peritoneal reflections. So in the tumor of the rectum, the peritoneal reflection, it is usually deeper in the females, as shown here. There is a recto-uterine pouch where the peritoneum is dipping more down as compared to in the males. There is a rectovesical pouch, so which has so in males there is a large bare area on the anterior surface when you see such specimens. And further, the upper 1/3 of the rectum, the peritoneum will be covered on the front as well as on the side, but middle 1/3 you see it only on the front, and lower third is completely devoid of the peritoneum. I will illustrate it further. So why it is important to know that whether tumor is above or below the peritoneal reflections, because it decides the further sampling and staging of the tumor accordingly. So as I said, that on anterior side, you can see the peritoneal reflection is lower, whereas on the posterior aspect towards the sacrum, there is a large bare area. Now coming to what type of specimens which we encounter when we are dealing with the colorectal tumors, it all depends on the site of the tumor, as well as it also depends on the vascular territory which a particular blood vessel is supplying. So we can get polypectomies specimen if there is only polyp, like lesion, right and left hemicolectomy, transverse and descending or sigmoid colectomies, APR and anterior resections for the low rectal and the sigmoid colon tumors, and total proctocolectomy if the patient is suffering from familial adenomatous polyposis. The two specimens which gives a problem to most of the people while grossing is especially in the rectum and the canal, is about what is AR and what is APR. Just to understand it in a simple language, in anterior resection, it is a sphincter preserving surgery, whereas the APR is done when there is a low rectal tumor which are close to the dentate line, And so in AR, you will not see anal verge as illustrated here, whereas in the abdominal or perineal resection, there will be the anal verge will be there, and the patient need to be on the there's a compulsory colostomy has to be put for that particular patient. So as I said, so in AR or intersphincteric resection, there is a you will not see the anal verge, but whereas in the APR specimen, there will be an anal verge at the distal margin. So otherwise, the grossing of both of these specimens will be the same. Now we'll start with how to proceed with the grossing of these specimens. First and foremost important thing, which is a very common practice when the specimens are sent to the pathologist, they are opened up by the surgeon because they are very curious to see what they have taken out, but it's not the job of a surgeon. So there is a need to teach and educate the surgeons that they should not open the specimen at their end. So if they are very keen, invite them to your lab and they can see the tumor and to open up the specimen in a proper way. If there is any history of neoadjuvant treatment, it should be always conveyed to the pathologist, and always try to check for the pre-surgery or pre-neoadjuvant RT or CT imaging findings, because it gives a very fair idea when you are grossing the specimen as well as when you are reporting, because many times, especially in the era of when there is a lot neoadjuvant CT and RT is given, especially for the rectal tumors, you may or may not find any grossly visible lesion. So in those scenarios, if you have upfront information about the imaging finding, it is definitely going to help you. Next, once you receive the specimen, so what is the first step? What is done commonly in the other specimens? When the specimen is received, we try to slice the specimen and put for fixation after the inking. But for the colorectal specimens, especially for the rectal specimens, we have to evaluate two important things. That is, assess the quality of meso-rectal excision, and that to evaluate whether there is any perforation present on the external surface or not. So why these two things are important, and because so what is TME? First of all, everyone of you should be aware of the thing that TME means is the removal of meso-rectal or perirectal pad of fat and block with the rectal tumor. So surgeon put a knife and remove a sliver of the perirectal fat around the rectum. So this is very much important, and this is relevant only for the tumor which are confined to the rectum. So if because inadequate or incomplete TME reflects the poor quality of the surgery, so it acts as a quality indicator for the surgeon. Another thing is if there is a good amount or complete TME is done, then the yield of lymph nodes will be excellent. And so if while grossing this specimen or reporting, if you find the less number of lymph nodes, then the surgeon should not blame a pathologist that you have taken out a less number of nodes, because it is the surgeon who has not given you enough of the perirectal fat, so you can't evaluate them properly. So another thing is how to evaluate the meso-rectal excision. So it is divided into the three grades, or complete, almost complete, and incomplete. Assessment is based on the presence of assessment of meso-rectum, rectal fat, about the defects, presence or absence of coning, and circumferential margin. One of the question was also put in the pre-poll. So if there is a coning, if it is absent, that means it is a complete TME. So I'll just show you a few examples as well as go into these things in a little more elaborative way. So here you can see there is a bulky meso-rectum which has a smooth surface and there are hardly any defects, or even if there are defects like this, they are not more than 5 millimeter in depth, and there is no coning. Coning means it is the lower part of the specimen. You will then there is a less amount of fat around it. It will appears like a cone shape. So if the specimen looks more like narrower toward the lower end, it means that coning is present. In near complete or grade 2 TME means there are irregularities are present on the surface, but which are more than 5 millimeter, but you can't see the muscularized layer. So here again you can see in the fixed specimen there is a defect, but you can't visualize the muscularized propria, and TME or incomplete TME means you can clearly see the muscular layer. So on the gross examination, so that means it is a incomplete TME, and likelihood of CRM coming positive in this case, as well as the yield of lymph nodes will be very, very low in this case. So likelihood of CRM being positive will be very high, and yield of lymph nodes will be very low. So another thing which I told you to check at when the starting of when you receive the specimen is look for the site of perforation. So if there is any perforation, you need to record it, because it directly upstage the tumor to T4b. Next step is we have to document the nature of the specimen, or what type of the specimen is there, and then palpate the specimen from the outside, because till now we have not opened it, to determine where the tumor is located and check for its relationships with the API, with the anterior peritoneal reflection or anal verge. So after this, what we have to do is the inking of the specimen. Inking of specimen, we have to paint only the bare area, not the serosa, because if you put an ink on the serosa, the mesothelial, the lining, which is very thin, and it might get disrupted, so you'll not be able to evaluate the serosal involvement confidently or with a certainty. So, so this is the illustrations how after the inking you put the ink on the AR specimen. So this is the posterior aspect, as I told, the bare area is larger. You can put different color inks also on the anterior and posterior aspect, as well as on the lateral side if it is required, because sometimes the clinicians know if the CRM is involved, they would like to give some boost of radiation to the particular area where the CRM is positive. So you should try to put different colors inks also on the different aspects of the this rectal tumor case specimens. Yeah. So so after you have put the ink the specimen, the next step is to look for the fixation of the specimen, for which you should try to open the specimen from both the ends, means proximal and distal margin aspect. But we have to ensure that not to cut through the tumor, and so try to stop around 1 centimeter proximal and distal to the tumor, and those areas we should not cut longitudinally, and At this same time, we can measure the distances, that is the proximal and distal margins of the specimen, and if it is a low AR or the interspheric resections, so those specimens should be sent to the for frozen section diagnosis. And then after fixation, fixation which is kept for the overnight, we start with the grossing of the specimen on the next day. So on the first day, we have to evaluate TME, whether there is any perforation is present or not, ink the specific, ink only the bare area without disturbing and without cutting through the area where the tumor is present. I'll come to that, why we are doing that. So as I said, next step is to check for the site of the tumor and its relation with the peritoneal reflection. So there can be three case scenario. The tumor can be either above the level of peritoneal reflection, at the level of peritoneal reflection, or below the level of peritoneal reflection. And why it is important. So if a tumor which is either above or at the level of peritoneal reflection, so in this you can see when we gross these cases, there will be serosa on the anterior aspect, whereas the posterior surface there is a bare area which we have inked. So anteriorly there is a covering of serosa, but this black ink area which you are seeing, it forms the CRM. So in this, so if the tumor which is present at or above the level of the peritoneal reflection, so you need to evaluate serosa as well as CRM both. Whereas if the tumor is below the peritoneal reflection, so in that particular case, because there is no peritoneal covering or serosal covering all around, so all the quadrangle of the specimens, there will be, you need to look for the assessment of CRM. So that is the major difference, why we need to know where the tumor is located. Is it at the level above or below the level of the tumor? As I said earlier also, there are two type of margins which we need to sample, proximal and distal margins. Which proximal and distal margins you can sample either even on the fixation, at least you should measure them before fixation. And CRM, I will come to about it more in details. So longitudinal margins, they are essential to sample at least when the tumor is at least 3 centimeters from the margin. But it is recommended to sample them in each and every cases. You should not even skip that, the sampling of proximal or distal margin if the tumor is away from the far away from the if the margin is far away from the region. But there are some certain exceptions where we need to be very careful because submucosal involvement of the margin is known, especially with the signet ring cell carcinoma, undifferentiated carcinoma, or the tumor which shows extensive lymphovascular emboli. So in those cases, we have to sample these proximal and distal margin very carefully. Usually the distal margin is closer one because it all depends on the vascular supply of the organ. As I said earlier, in low AR specimen, we have to check, do the margin assessment in the frozen section. And if there is a tumor is arising in the background of IBD, then the margin should also be looked for presence of active inflammation or any presence of dysplasia. Now coming back again to the CRM and about serosa. So what is the clinical implication or the difference between these two things? So CRM is an actual surgical margin, which I told you when I was describing the TME, why it is a surgical margin, because surgeon has actually cut through that part of the fat and to put the specimen out. So CRM is a surgical margin, but it doesn't affect the TNM stage. So even if CRM is positive, the tumor will still remain as a T3 and it will not become as a T4 lesion. But in contrast, cirrhosa, it is not a surgical margin, it acts as a natural barrier. So if there is a cirrhosis involvement, it becomes a T4 disease, which has a worse prognosis. Or any CRM positivity, it means the patient needs adjuvant radiation and the likelihood of local recurrences are very high. So as I said, the CRM is one of the most crucial component which as a pathologist we need to assess it properly, and then can we assess it properly if we ink that area properly, if we cut through the tumor properly, and if any CRM positivity means the patient needs adjuvant therapy, especially radiation. So all CRM sections which we have taken from the CRM, they need to be evaluated and confirmed microscopically, and so only if if microscopically they are free, then only we called as a the CRM as a free, and you can see that this is the ink which is coming on the tissue sections section on the histological slides, and based on that you can make a clear evaluation about the CRM. So when do we call as a CRM as a positive? So CRM positive, the criteria that if you see the tumor which is either at the margin or it is at the less than 1 millimeters away from the ink margin, it can be regarded as a CRM positive. Another important thing is it there are, if you can get CRM positivity either due to the direct tumor extension, or there can be any node or lymphovascular emboli or PNI at the ink margin. So even if you see that is also regarded as CRM positive, but you have to clearly state in that case scenario in your report that CRM positivity was due to the metastatic node at the circumferential resection margin. If acellular pool of mucin, if you see in a post-NECT scenario, that is not to be regarded as a CRM positive. So you can see there are pools of mucin here, which are very close to the ink margin. But this, if there are only acellular pools, you should not regard this as a CRM positive. But in such scenarios, you have to do additional sampling of for the CRM to be 100% sure that this case in this particular case CRM is definitely negative or not. As I earlier also mentioned that there are some other areas where there is a non-paternalized surface. So these areas should also be sampled, similar to the I explained you for the rectum. Now, how do you cut through the tumor? So when a segment of intestine which is containing a tumor, it should be serially sliced like this, and each and the slicing should be done transversely. So the tumor area, it is recommended not to open it longitudinally, because why it is to be done, because it gives a better orientation of the mucosal of the layers of the intestine, and you can assess the depth of invasion more critically, or your on the depth of invasion as well as on the CRM involvement. So as I said, that the transverse slicing through the tumor, it is definitely advantageous because it gives an idea about the anterior and posterior relations with the CRM as well as cirrhosis very clearly. Exposure of exposing the maximum surface of the tumor so that you can choose which area to be sampled more clearly and more very critically. So in this illustrations, you can see that the rectangular boxes which we have shown, these are the areas from where the tumor, from the sections were actually taken. So we have to take the areas where the worst area should be sampled. As I mentioned earlier also, although we need to document the tumor size, but it has no prognostic significance. But the gross appearance of the tumor gives an idea about the, whether the tumor is, if it is a polypoidal tumor, it might have arise in the background of adenoma. If it is a circumferential tumor, the patient might have a constrictive or obstructive symptoms. As I mentioned earlier also, that we have to sample the worst looking areas, and if the dimension of the tumor is a large and you are not able to fit any particular the whole slice into a single block, it is recommended you divide the section into the 2 or 3 parts and clearly mention in which, like here we are done with that 1A, 1B, and so section 1C represents the CRM and section 2B represents the serosal aspect. So these, at the time of grossing, we have to label them very carefully. So all tumor sections should be of include the full thickness till the CRM or the serosa and worst sample areas to be submitted. Why it is important? Because it defines the T stage of the lesion, and so it is a responsibility of a pathologist to do that. So now I'll just quickly go through some of the tumor category or the T stage related issues. So just to start with, between the initial intramucosal lesions or carcinoma in situ, is there any need to put these 2 different diagnostic categories? If you see, as per clinical outcome, it is not relevant, but as a pathologist, we call in situ carcinoma only if it is involving the lining epithelium, whereas the intramucosal carcinoma, there is a lamina propria is involved. Another point of debate occurred when to what is the definite criteria to distinguish between T2 versus T3. T2 means tumor is confined to the muscularis, and or as a T3 when it has invaded the muscularis propria or not. So to be very more objective, and in order to avoid the inter-observer variability, we should see some area where there is a definitive lack of the smooth muscles and the tumor is seen clearly going to the pericolic fat. Although there is no discrete division between the T3 tumors, but it is recommended if you can further measure the actual depth of invasion into the pericolic fat, like is less than 5 millimeter or more than 5 millimeter. It further helps the clinicians to decide on the adjuvant therapy. And at the last, about the histological assessment of T3 versus T4 colorectal tumors, and this is one of the very relevant point because the outcomes are drastically different, and there is a high chances of local recurrences if it is a T4 tumor. But this assessment is very largely underreported, and there are reasons for it. First and foremost important is the inadequate gross examination of the serosa, aspect of the lesion, and another thing, there are some practical difficulties also which are associated with the histological assessment of real or the true serosal involvement, because there are diagnostic criteria were earlier not very clearly defined, and at the last we have to be very careful whether the breach in the serosa is it a real breach caused by the tumor, or is the iatrogenic breach during the specimen handling, either by the surgeon or by the pathologist. So when there is a not a clear-cut serological involvement, attempt should be made to look for the areas which are called as the devices of serosa, because here there is a, you can see there is a depression or dip in the lining from the fat. So these are the areas which are likely to show involvement and involvement or serosal involvement, and sampling from such areas is very critical. So it is as a pathologist, it becomes our moral responsibility to examine the serosal aspect very carefully for any areas which is showing puckering, retraction, granularity, or increase in the vascularity. And even though grossly you are not able to see the tumor, so these areas need to be sampled. As illustrated, we can see this area under the microscopy. The area represented from the serosal crevices, which shows the evidence of a tumor, whereas most of the serosal surface appears to be free of the tumor. Then another issue came up when we have to call the tumor as a T4 or the definitive serosal or peritoneal involvement, because this is one of the very robust parameter for the local recurrence. So if there is a tumor, if you see the tumor at the serosal surface, then it is called as clearly as a T4a. In addition, if you also see if there are free tumor cells on the serosal aspect with underlying erosion, ulceration of the mesothelial lining, mesothelial hyperplasia or inflammatory reaction, those scenarios also to be labeled as a serosal involvement or involvement of the visceral peritoneum. Or if there is a perforation in which the tumor is continuous with the serosal surface through inflammation. So if there is an ulcer caused by the tumor, so as demonstrated here, again, serosal crevices, you can see there is a lot of ulceration and the ulceration with the inflammatory response, and the tumor is seen at the surface. Here on this picture C, you can see all the serosa appears free, but there are a lot of inflammatory or the serositis like response over there. So in such scenario, you have to sample additional areas or even do the serial deep cuts of the sections, which might show you the presence of the tumor actually at the surface. So as I said earlier, so these are the few challenges which you routinely encounter when you are reporting on the serosal involvement. So if in a doubt, take more sections of the deeper cuts. Can we use any additional adjuvant ancillary techniques? So elastic stain were attempted by some of the researchers, but it is not a very robust and established till now, as it was established for the pleural involvement in the lung. And in addition, you have to do elastic, if in doubt, to do elastic stain on the multiple sections, which might not be the feasible for all the cases. If there are peritoneal washing, or so try to correlate your histological findings with that. Acellular mucin on the surface, serosal surface in a neoadjuvant setting, it is not to be regarded as a PT4a. And if you are not seeing the tumor, which is even after making all these attempts, and the tumor is not reaching up to the serosa, it is still to be labeled as PT3. Moving on to the next to the about the lymph node status. Lymph nodes also are equally important as the T stage, and 12 nodes are the minimum standard recommended for the colorectal specimens, and we need to sample the lymph nodes at the level above and below the level of the tumor. And when we are dissecting the nodes from the prolific fat, we have to take care first. We should take the sections for the tumor infiltration, and even if you're able to see that some lymph nodes in those sections, those can be included along with the primary tumor sections, and don't try to remove these lymph nodes because it might hinder with the evaluation of the actual CRM in that scenario. And apical nodes was used to sample, and this was a part of earlier Duke staging. So number of node positives should be clearly defined, and if there are N1, N2, and one is further divided into if there is one node positive, if there are 2 to 3 node positive, it is called as M and 1B, and similarly N2A and 2B. So our as a pathologist report should clearly state on the number of the lymph nodes examined and the total number of the nodes which are examined. So minimum cutoff figure which is given recommended is a 12. So there are some node category related issues. First is and the foremost important is about the total lymph node yield. What are the tumor deposits, and if you see the acellular mucin in the lymph nodes, how to date them. So acellular pools of mucin, if it is a post-neoadjuvant setting, they should not be regarded as positive. But if the patient has not received any therapy, so those in those particular case scenarios, you have to do the additional either sampling as well as the serial deposits of those nodes. Lymph node yield, as I said, it depends on the multiple factors. Is it a surgeon's fault or a pathologist's fault? It's always debatable. But in addition, there are some patient-associated factors in which, like right-sided tumor, MSI, high tumors, and female gender, they have a high lymph node yield, whereas in elderly, left-sided tumors and the post-neoadjuvant setting, the lymph nodes yield is low. But at the same time, even if you're not able to grossly see the significant number of the lymph nodes, but you have to be aware of the fact even there are very tiny nodes, even less than 5 millimeters, they can be positive. So extensive sampling, and if you get the lymph node less than 12, go back to the specimen, try to sample more. And there are some certain fat clearing agents are also recommended to use, and they are available, but we have to be careful that they should not impact the T stage of the tumor. So even after making all these attempts, if your lymph node yield is low, then it needs to be clearly communicated to the treating physician. What is the tumor deposit? That is regarded as a N1C category. So if you see a tumor focus in the pericolic or perirectal fat, in the vicinity of lymphatic drainage, but without identifiable node, these are called the tumor deposits, and it should be reported as, because this is, if there are no other bad poor prognostic factor, this can be regarded as one of the criteria for adjuvant therapy. Care should be taken; they should not be in the vicinity of any vessel or nerve. And further, we should be very careful, especially in the post-neoadjuvant therapy, to report as a soft tumor deposit. So these are the various sections which we need to take when you are dealing with the colorectal specimen, from the tumor with the cirrhosis and CRM, all lymph nodes, the longitudinal margin, and any abnormal or adjacent area. Adjacent colon, we should look for any presence of adenomas, or any changes of IBD, perforations. So moving on, another specimen which we have to be careful while grossing is a polyp, and we get it very commonly. I just want to stress on the fact that while grossing the polypectomy specimens, we have to keep our prime focus on the base, and the section should be taken in such a way that the base of the polyp, whether it is a pedunculated or is a sessile polyp, it should be sampled so that you can do the microscopic evaluation properly. Now we have to follow the 8th TNM, and 8th TNM for colon cancer, there is very less changes in the 8th TNM as compared to the other sites. So only M1C is the additional M stage which was added. Towards the end, I'd like to stress on the resection or evaluation of post-treatment specimens, because histopathological evaluation is considered to gold standard for these cancers, and depending on the treatment response, you will get a specimens which might show the variable gross evaluation. So if you're not seeing any definitive area, we have to sample areas which shows mucosal irregularity, congestion, ulceration. And on microscopy, we have to report that the tumor regression grading. Either you can use the Mandard grading or modified Ryan scheme, because Ryan is a 3-tier system, so the inter-observer reproducibility is better. So this is very much important, especially in the rectal cancer, which are post CT and post RT. So because sometimes if you sample only on from the surface, you are unlikely to get the tumor, but the deeper areas are likely to show the presence of a tumor. So you have to evaluate these across these cases very critically. So these are the snapshot of what are the all findings we need to report on gross as well as on microscopy. So it's better to keep a checklist of all these things, so that you should not view the specimen when you gross and handle it correctly. With this, I end my talk on the grossing of colorectal tumors. I invite Dr. Monita for comments.
Thank you, Rajiv. You have done an excellent job. It was a very thorough and detailed talk on crossing of the colorectal specimen, which is one of the very common specimen, I would say, and also very commonly mishandled if we don't know how to cross it. So as far as the normal histology is concerned, we are pathologists. Whatever is not normal is pathological, and we have to know what is normal. So normal histology, without knowing the normal, we cannot do what we do, and that is to identify what is not normal or pathological. So as far as the grossing is concerned, you have already done a very, very good job. I will just summarize and just basically speak to the trainings or the postgraduate students, just because I feel that grossing is one of the area which tends to be neglected. Let me just share my screen. So is it visible now?
No, it's not.
Okay, so what I feel is that during our whole training and our postgraduate period, we are mainly focusing on microscopy and making a diagnosis and learning how to make a diagnosis. And what we tend to do is this is an area, grossing is one area which tends to be neglected. And when you ask a trainee why we do a grossing, it is mainly because they are posted in grossing, and when we do grossing, it is mainly how the seniors have told us to gross. So I would like to change the attitude.
Dr. Monita, your screen is not visible.
Dr. Rajiv, have you turned your screen share off?
Yeah, yes, I have.
You have, okay.
So is my screen visible now?
No.
Yeah, could you try once again? Yeah. You can do the screen share and then click on the PPT.
Yeah.
Yeah, open your PowerPoint. I think we can see your screen, but yes.
Okay. Okay. So what I basically want to say is, when we do, how do we gross? Before we gross, we should know that basically grossing is very important, because it is the first step towards making a complete report. No matter how expert you are. If your grossing is not done properly, you will not sample the proper areas, and it will affect your report. You cannot give a good report if your grossing is not good. So broadly, there are two types of specimens that we get, and every specimen that comes to us has a set of questions, clinical questions that we are supposed to address. So
Monica, could you go full screen, please? Full screen.
Oh, sure.
Yeah.
And okay, so so I was basically saying that as a pathologist, what our job is to basically address the clinical questions that come with each specimen. So, and broadly, we have two types of specimen. One are the biopsies, where the main question, the clinical question is what is the diagnosis, and we have to basically submit the entire thing to, and our job is to give a histologic diagnosis. And the others are the curative dissections, where we have to go beyond, our job extends beyond diagnosis. So it is not just the diagnosis. And most of the times when you get curative dissection, you already have, the surgeon is already aware of the diagnosis. And what you basically want to give is something that would help in treatment. So very basic for trainees to say that when there is cancer treatment, not only curative surgery, so one of them technical treatment is curative surgery, but some of the patients will require, in addition to surgery, they will require adjuvant treatment either in the form of radiation or chemotherapy. And which are these patients who will require adjuvant treatment or additional treatment depends upon what are the factors in the pathology examination after on the surgical specimen. And these are the patients, it is your pathology report that will decide who will go for, in whom the surgery is enough or in whom additional treatment is required. And in some of the cases where the upfront surgery is not possible because the tumor is too large, the new adjuvant treatment is given, that is therapy or chemoradiation is given, and in very commonly in our settings, new adjuvant chemoradiation is given to downstage the tumor, to shrink the tumor, operable negative margin. So many times you will get in rectum as well as in stomach, esophagus specimens which have been treated with adjuvant chemoradiation or chemotherapy. And it's important to know what specimen you are handling, and it is your pathology report which will decide whether only observation is enough or whether treatment is required. So in your report, in your final report, the key questions that a surgeon or an oncologist is looking for is whether the section specimen sent is the surgery complete, what stage, what is it in advanced stage? If it is advanced stage, then he would require need to give adjuvant chemotherapy or radiation. If the surgery is not complete, again it requires some additional treatment or revision of surgery. And the thing they want to see is, are there any adverse features or prognostic features which suggesting aggressive biology? And that these form the goal of grossing. So you have to give the completeness of excision by looking at the margins in GI tract. And the margins will depend on the type of the specimen you see in the GI tract. And for especially colorectal, you have not only the longitudinal ends of the gut, but you also have the circumferential radial margin, which Rajiv very beautifully and elegantly described. The second is the TNM, which is basically what is the extent of the tumor and what is the metastasis. If the TNM is advanced, again patient will receive adjuvant therapy and prognostic features. So you have to sample extensively to see if the tumor has some adverse, which will decide treatment. So your job is not only as a pathologist to give diagnosis, but also provide important information which surgeon can use to guide further treatments. And before we do grossing, it is very important. We should not mishandle the specimen. We have to preserve the specimen, immediately fix it, and see that it is well preserved, and also we don't have to damage it, cut it open before inspecting it, because you can lose valuable information by that. We should stop and pause and see what is the patient's, is it a polyposis case? Is there a history of IBD? What type of specimen is it? Is it just an anterior dissection, or there is a limited exenteration? Has the surgeon also sent some vaginal wall with it, or a seminal vesicle, or it's a total pelvic exenteration where you have uterus and urinary bladder as well. So you have to see what type of specimen it is, and that will also decide what type of what is your sampling would be and what your margins would be. And very important, especially in rectal tumors, to see whether any previous neoadjuvant chemoradiation was given. Now in stomach and esophagus also you get neoadjuvant therapy. So fixation without a doubt is extremely important, and there should be an urgency to fix it as soon as possible. And before you start crossing, it is important that you also urge your clinician to not send, or your surgeon to not cut open and send the specimens, because that can compromise the evaluation of CRM and the serosa. So you should insist that your surgeons send the specimen intact for proper evaluation. Tumor perforation, as Rajiv has said, just summarizing what important features that we have to see. Never forget to see tumor perforation, and it will hardly be a gaping wound. Most of the times it is sealed, it is covered with exudate, so you should not scrape it. Rather, those are the features which Rajiv very beautifully highlighted, and they are important. If your report does not mention that tumor perforation is absent or present, your oncologist will call you and ask you whether tumor perforation is present or absent, because that is an adverse feature. Identifying serosa and distinguishing it from CRM, again elegantly told by Rajiv. Before we start chopping, inking, we have to inspect the specimen and see whether it's a total meso-rectal excision or not, and that is something only the grosser can evaluate. And then we do a thorough examination. And extremely important to emphasize that lymph nodes are extremely important for staging. If you have less than 12 lymph nodes, then the patient is not optimally staged and may receive inadequate treatment, or may by default will have to be given chemotherapy which may not be indicated. So you have to regross till you find a minimum of 12 lymph nodes. In post-NSATRT cases, you have to sample the tumor extensively. Sometimes the tumor may not be visible. Then you have to see where the tumor bed is and palpate any induration or lesions which were seen in the endoscopy. They have to be submitted completely. So checklist we already know, and it is our pathology report which decides. So it is extremely important, and I would urge Rajiv to get back to his next presentation.
Thank you, Dr. Manita. Can you see my screen?
Yes, sir.
Yes, visible. Yeah. So now we'll move on to the crossing of the pancreas. We start with the basic anatomy. We all know that pancreas is both exocrine and endocrine organ, and it is seen in the second part in proximity with the second part of the duodenum, and has a big head, body, and tail, and uncinate process. These are the anatomical landmarks or the structures of the pancreas. As you can see that the pancreas is seen in proximity to not only many organs, but also there are a lot of the vascular structures, and even the ducts like CBD, they are in close proximity to the pancreas. So when we deal with these the lesions in the pancreas. Many times, in addition to the pancreas, there is a composite resection where these elements are encountered. So coming more into some basics or into the anatomy, there are, as we know, that pancreas is a lobulated structure, and there are two drainage system of the pancreas is through the pancreatic ducts, which join the common bile duct and open into the ampulla. And here grossly the pancreatic duct is illustrated, which is transversing through the pancreatic parenchyma. This arrow illustrates the common bile duct, which later join this smaller pancreatic duct. So usually the common bile duct is larger in diameter and seen on the posterior aspect of the pancreas, and both they can either open into the duodenum through the ampulla or major or minor ampulla. As I mentioned earlier also, that this is a lobulated organ, but there is no definitive capsule around the pancreas. So why it is important to know that there is no capsule, that means all the surfaces the surgeons need to dissect out the organ, and white represents the resection margins. Briefly about the histology of the pancreas, it is composed. There are two, as I said, it has both exocrine acinar cells and endocrine cells, which are from the islet of Langerhans, which is demonstrated here. And as I mentioned, the acinar cells, which forms around 80 to 85% of the pancreas, and they drain through the intercalated ducts to the interlobular ducts, which are usually highlighted. You can see that they are nicely highlighted by the use of ISC. So these as acinar cells, they drain to the intercalated ducts, and there are small intralobular ducts which are within that particular lobule, and there is very small fibrous tissue around it. And within these lobules, although the boundaries are not very well established, there are larger ducts. These are called interlobular ducts. And one of the important thing about the pancreatic ducts, we should know that there is no muscular layer around it. And so this is very important when you want to say whether the tumor, if you see a duct-like structure and there is a tumor, is it really a duct or is it an emboli of the emboli? Another thing, interstitium in the pancreas is very scanty, although interlobular ducts are seen in these areas. And why it is important to know, especially like a disease like chronic pancreatitis, you see a lot of increase in the interstitial, either fibrosis or the fat. And this interstitium, only you see so you can see the nerves, and around the peripancreatic fat or adipose tissue also you will be able to see, you can recognize many nerves, so which is the reason why the pancreatic lesion gives a lot of pain. Further, as I said, the drainage system, pancreas drain through the pancreatic duct, and which opens through the ampulla. And here you can see how the normal histology of a ampullary region. You can see there is a duodenal lining, and below which there is ampullary. There is a ampulla, and you can see besides the sphincter of Codi, there is hardly any muscular layer in any of the pancreatic ducts. So this is the landmark. So here there is more of muscular tissue around it, and the lining epithelium is called columnar towards the end. But in the ampullary region, there can be transition between the duodenal mucosa. Do you want me to show the live slides, or should I continue with this? Because the time is less.
I think so, you can continue.
Rajiv, time is not an issue. Please continue.
Yeah. Okay. No, digital slides. Should we show the digital slides of normal histology of pancreas, or
why not?
I have explained it here. Quickly, I can show it. Run through it. So, as I explained in my presentation, that the pancreas is a lobulated organ, and which is also depicted in the microscopy. With, you can see there is a very hardly very tiny amount of interstitial tissue is there. So these are the lobules which are divided further by these scanty interstitium into the further into the interlobular septations. So as you can see, so these are the areas from the pancreatic acini. We can see a lot of these periphery eosinophilic cells. They are pancreatic acinar cells, and towards the center there is the cluster of islet cells. And again here showing some of the tiny ducts-like structure, which are intercalated ducts. Just to again illustrate the islet cells, which are surrounded by the acinar cells. And these are slightly larger ducts, which are lobar duct, and which relatively more of a fibrous tissue around it, which finally they drain into the interlobular ducts and through the ampulla into the duodenum. So I'll just again focus a little bit on the ampullary region, and here you can see there is a large common bile duct which is going to open to the major to the papilla into the duodenum. So this is about the basic anatomy and histology of the pancreas, and now moving to the which type of specimens you will encounter when you see the lesions in the pancreas. The most common specimen which we see is called as a Whipple's surgery or the pancreatic cord duodenectomy. So as you can see, which all segments are removed here. There is a part of part of stomach, duodenum along with the pancreas and gallbladder, and few blood vessels are removed. And now there is a procedure called modified Whipple, in which pylorus is preserved. So only the second it starts with the resection starts with the first part of the duodenum, and the pylorus of the stomach is preserved. So when we get the Whipple's specimens, we can see the tumor at three primary locations. Like either it can be the periampullary tumors or the tumors which are arising from the ducts, or that is a extrahepatic bile ducts, or intrapancreatic part of a common bile duct, or the tumors of the pancreas as such. In addition, sometime in addition to the Whipple's surgery, you can also get the specimens like a distal pancreatectomy with splenectomy. These specimens are more commonly seen. You will encounter when the surgeons can preserve the duodenum, or the tumor is present towards the tail end of the pancreas, or maybe some neuroendocrine tumors. Another specimen type, if it is completely cystic lesion, which can be easily taken out, denucleation specimen can also be taken. So the grossing of the pancreatic lesions, it is more tricky and complicated, mainly due to the complex anatomy and the many structures around it. And further, there are many conditions like inflammatory and neoplastic conditions. They have overlapping features, and you might get a similar clinical or the imaging findings. So the careful evaluation on the grossing is very important. So the goal of grossing is first, when we encounter any Whipple's specimen, is to first to define the epicenter of the lesion, whether it is a periampullary, pancreatic, or CBD, and define the completeness of the surgical margins and determine the TNM staging. So as how to handle these specimens in a fresh state, as I mentioned earlier, the surgeons should refrain from cutting, and they should not spoil the specimens, because if the pancreatic specimen is cut without proper recommendation or the proper care, the evaluation of the margins and other parameters will not be possible. Sometimes there is need to give the sample for biobanking. That time also we have to be very careful so that your routine diagnostic reporting is not hampered. Then, while for fixation of the pancreas, we have to clear all the, open the hollow organs, like if there is a part of stomach or gallbladder is attached to it, you have to ring them carefully, otherwise fixation will not be proper. And especially you will see the autolytic changes, especially towards the peripheral part of the pancreas. And another thing, while slicing, we have to keep in mind, we should not, there are some protocols of dissection of the pancreas that should be kept in mind even at the time of fixation, because you can't change it later on. So when the specimen come to you, you have to first orient and identify the specimen, measure all the relevant dimensions, and try to identify the various surfaces. So pancreatic surfaces, they are very, very important because they form the very crucial resection margins. And in pancreas, it is recommended to use a different color inks to mark these surfaces, because post reporting, during the reporting, if you mark them with only one color, then it will not be possible to distinguish that whether the tumor is involving the which surface. So it is always recommended to use a different color for marking these surfaces. And why it is important? Because there are two types of margins in the pancreas. One is the transectional margins, and another is the circumferential margins or the surface margins. So the transection margins in the pancreas, they are the distal and proximal duodenal or the gastric margin, CBD margin, and the pancreatic neck cut margin. So these are the three margins which are called as a transection margins. But in addition to that, we have to also sample the pancreatic surface margins, which forms the sort of CRM for the pancreas. So in pancreas, there are four surfaces which are relevant. First one is the anterior surface, which is usually very smooth and shiny. Why? Because there's no need to dissect that or surgically cut on that area, so that the pre-port question which we have put, the pancreatic surface or anterior surface should not be regarded as a real margin, but it should be reported if the pancreatic anterior surface is involved. That comment should be made, and you can get if the tumor is invading also into the colon, especially the transverse colon. In those cases, the involvement of anterior surface become more relevant. So anterior and posterior surfaces, they can be easily identified and should be marked with a different color inks, as I mentioned earlier. The another important surface is the vascular groove or the vascular surfaces. So there are two things. One is the SMV surface and SMA surface. How they are different. So as you can see in this illustration, the superior mesenteric vein, this vein can be easily taken out by the surgeon because it is not adhere to the pancreatic surface, because it just lies on a groove. Whereas the red color superior mesenteric vein, it is retroperitoneal and attached with the fascia, so it need to be dissected out by the surgeon. So you can see this is there is a clear groove without with very little fat, which is called as a SMV surface or on the median margin. So it is inked with a green coloring. And why it is important to identify this area, because there is very little fat present in this area. So likelihood of this area coming positive is very high. And another area which I told you as a SMA surface, it is a raw area similar to the pancreatic neck cut margin, which should be sampled adequately. And so SMA surface is usually towards the posterior and left of the SMV surface. So why it is another thing, why it is these surfaces are important, as I mentioned, that they are to be regarded as a CRM or circumferential resection margin for the pancreas, and there is very grossly underreporting of this margin especially in the pancreatic tumors. So even despite of extensive surgery, because Whipple surgery is a morbid surgery, the outcomes of many pancreatic tumors is not good, because they are devoid of adjuvant therapy due to lack of the adequate comment on these surfaces. Another important thing before we proceed to actual glossing, because many times the stents are put in the pancreas in the CBD to relieve the symptoms. So these stents should ideally be removed before you cut through the pancreas. So if they are metallic stents, then you need to be removed carefully. The plastic stent can be taken out easily. Another step is to identify the tumor. So sometimes you are not, if there is palpable mass, it can be easily identified, but sometimes you are not able to localize the tumor from the external surface. In those scenarios, you have to look for whether there is any ulceration or irregularity in the duodenal mucosa or the ampulla. Is there any irregularity or bulge on the pancreatic surface or retraction, especially towards the SM surface? So these are the few recommendations can be used to identify where the tumor is located. Next, how to gross the specimen, how to slice the specimen. There are three common modalities which are used. The initial recommendation, it was used as to do the bivalving or multi-valving techniques. In this, there's a probe is put through the CBD, through the ampulla or through the pancreatic duct, and the incision is made parallel to that. So you can see if you do the bivalving, the ampulla and pancreatic ducts or the pancreatic ductal structures, they are very well appreciated. So in this this method is recommended for if you have to evaluate the ampullary tumors or the tumors which or the cystic tumor of the pancreas, because it gives a better orientation of the tumor of the ampullary tumors with in relation to the pancreas, and also helps to identify cystic tumor, especially IPM, and whether it is involving the main pancreatic duct or the branching ducts. Other methods which are recommended for the pancreatic grossing is deadloafing or the slicing of the pancreas, in which the parallel the pancreas slicing is done perpendicular to the neck. So just slices are done next to the pancreatic neck cut margin, but the problem occurs when you reach is close to the duodenal surface, so it is not good for the periampulary tumors. But so the widely accepted method is the axial slicing technique, in which pancreas is sliced perpendicular to the longitudinal axis of the duodenum. So you can see that here the pancreas they are slicing, doing the serial slicing perpendicular to the axis of the duodenum, and this is one of the recommended method for the dissection on grossing of the pancreas. And all these slices then need to be carefully evaluated, and they are placed cranio-caudally, as you can see here, and we need to see where this tumor is present. And in this particular case, you can see the only one slice which is showing the tumorous growth in the ampullary region, and we need to localize, see the tumor location as well as its extension into the adjacent organ. So this is another illustration which can show that in this axial method we can identify these all surfaces very carefully, and here this is one of the case where you can see this anterior surface which is marked with the orange color coloring. So this method is very well very good to see the relationship of the tumor with the pancreatic surfaces, and also with its maintain its orientation with regard to the ampullary region. So here you can again see this is the anterior surface, and this green coloring is the region from the vascular area or the SMV surface, and posterior surface. As I said earlier, also SMV groove, here you can see the tumor is reaching up to there. There is a very little fat in this area. So the axial slicing method helps to pick up the lesion. So in one slice you can feel that tumor might be only purely intraductal, but further slices may give you idea that tumor is not only invading to the adjacent pancreas but also to the surrounding lymph node. And as I mentioned earlier, we have to be very careful while doing the gross evaluation, because many of the benign conditions of the pancreas, especially chronic pancreatitis, can mimic the malignancy, and the gross features of these can be exactly similar. As you can see, there are pseudocysts, dilated, there are a lot of dilatation, areas of hemorrhage and necrosis, and there are fibrous responses. So these can mimic on gross examination as a malignancy. So critical sampling and microscopic evaluation is required. Then further moving on to the lymph nodes, there are groups of the lymph nodes around the pancreas, and they should be sampled adequately. And there are some societies of which label them as a lymph node station. And for lymph node dissection, there are two methods which are commonly used. One is by the Verbeek's method, in which there is extensive perpendicular sampling of the surrounding fat is recommended, and there is another method in which is called as the orange peeling method, in which the whole of the peripancreatic soft tissue around the pancreas is removed, but it might have implication on the actual marking assessment. So we need to be very careful. So just to illustrate how the distribution of the nodes in this particular case around all the surfaces of the pancreas. So So there is a need to sample as much as not only the grossly visible node as well as the fat around this. So, and is there any cutoff for pancreas? The cutoff is not established, but it is recommended to dissect minimum of 12 to 15 nodes to have a complete mechanism. So while grossing of the pancreas, these sections to be submitted at least 4 blocks of the tumor, and attempt should be made to have one whole mount section in which a proper orientation of the tumor from the right from the duodenum to the infiltration into the pancreas can be maintained. The area from the adjacent pancreas, duodenum and CBD to be sampled. And there are, as I mentioned earlier, there are 2 types of margin: transactional margin and CRM, or the surface margin should be sampled and labeled adequately. For the distal pancreatectomy specimens, they need to be, while doing the crossing, they need to be serially sliced perpendicular to the longitudinal axis, and only issue with these specimens can come about the orientation. So either the surgeon should orient them properly, or the splenic vein usually runs along the superior aspect. So through that you can assess the surfaces, which are anterior, posterior, and superior inferior surfaces. So the margins in these specimens are pancreatic transaction margins and anterior and posterior surface margins. So in pancreatic resection specimens, you have to measure, document the type of the specimen, record all the dimensions of the specimens, and also need to record the various tumor characteristics like appearance, size, and localization, and about their relationship with the margin. And these all parameters should be confirmed by the microscopy, because the gross evaluation, especially about the margins, can be wrong on the gross. So I like to share some snapshots of the changes which are done in the recent TNM staging of the pancreas as compared to the TNM7, which was earlier used. So now the TNM for pancreas is mainly based on the size, and the extra pancreatic extension is no longer a part of the TNM staging, T-staging of the pancreas. So, and T1 tumors are divided into T1 A, B, and C. T2 tumors are the tumor which has size less than 4 cm, more than 2 but less than 4 cm, and T3 more than 4 cm. So extra pancreatic extension is no longer a criteria for deciding the T3 stage of the pancreatic tumors. And similarly, not many changes happened for ampullary tumors in the 8th TNM. T1 is tumor is divided further into 2 subtypes, whether it is limited to the ampulla of water or going beyond it. T2 tumors, earlier it was only the tumors which invade the duodenal wall, but now they have clearly defined that it invades the muscular propria of the duodenal wall. And in T3, tumors are divided into T3A and B, depending on how much is the depth of invasion into the pancreas. So T3A is less than, it's up to 0.5 centimeter, and if it is more than 0.5 centimeter, or if the tumor extends into the pancreatic, peripancreatic soft tissue, it can be regarded as T3B. So peripancreatic extension is only relevant for ampullary tumors and not to be used for pancreatic tumors as such. Further, there is a need to, on histology, there is a need to tell whether the tumor is of intestinal or pancreatic or biliary subtype, because the tumor which has a pancreatic or biliary subtype phenotype, they have aggressive behavior and need to be treated using the gemcitabine. So that is another thing which we need as a pathologist, we need to tell in the tumor classification. Finally, about resection margins, when will you call margin positive or negative in pancreas? So if any margin, if the tumor is more than 1 millimeter away, it can be called as a R0 resection. But if the tumor is within 1 millimeter of the resection margin, even if it is not at the surface, it is to be regarded as R1. Or similar to the colon, even if you see any lymph node or the lymphovascular emboli or perineural invasion at the surface, they are also considered R1. But they have put a rider for the vascular invasion. So the tumor should be, if the tumor is attached to the vessel wall, then only it should be regarded as an R1 resection if you are using only vascular invasion as a criteria. So with this, I end my talk, and I like to thank all my DMG colleagues and my DMG GI pathologists, Dr. Mukta, Dr. Kedar, and Dr. Munita, and some of the slides and I've used from their presentation, and thanks for sharing those slides with me, which can be used for this academic presentation. Thank you very much.
So thank you, Rajiv, for an excellent presentation. And for the sake of time, I would just like to summarize that when we are dealing with a pancreatic resection, it can be a very intimidating specimen, and because it's a lot of structures anatomically, lot of structures which are in that very small space. So what is very important I want to highlight is that when you are crossing a pancreatic resection, it is very important to determine where is the tumor. Is it because very easily people try to club it to a periampullary tumor or a pancreatic tumor without giving due importance to the tumor epicenter. So that is something that only the crosser can, or the person who's crossing can do justice to. So it is very important that we identify what is the tumor origin or what is the tumor epicenter, and try to see where is the bulk of the tumor. Because this periampullary region is comprising of not only the pancreas, but also ampulla, CBD, terminal end of the CBD, and the duodenum as well. So these four subsites are very closely placed anatomically, and very often we find that tumors of the ampulla will involve the pancreas and the terminal end of the CBD. But even so, if we do a careful examination, we can determine where is the bulk of the tumor. Is the tumor epicenter is centered on the ampulla, or may predominantly along the terminal end of CBD or the pancreas. So there will be a small subset which you may not be able to determine the epicenter, but still that effort should be made at the time of crossing to determine whether it is an ampullary tumor, or a distal CBD tumor, or a pancreatic tumor, or a duodenal tumor, because these are four biologically very different diseases with different prognosis, and these need to be corroborated on the microscopy section. So in pancreatic crossing, one of the most important things is to identify what is the tumor origin. Then secondly, I would like to say earlier the margins were transection margins, but now we also have the so-called CRMs, or the pancreatic surfaces, also included in margins. And of these, only SMA is the one which is actually a surgical margin. Rest all are prognostic margins, because they, just by involvement within 1 millimeter, they lower the prognosis or worsen the prognosis, and there is very little that the surgeon can do. So by that means it is not a surgical margin. It is the SMA surface which the surgeon can control, but the rest are more or less prognostic margins. So the definition of what is a positive margin in pancreas involving these surfaces has been controversial, but where we are right now is that 1 millimeter cutoff, similar to that which is used in rectum, is also applied to pancreas. Whether similar criteria of microscopic involvement of a metastatic lymph node at margin, or LVI at margin, or perineural invasion indirect modes of involvement close to the margin, are they included or not? That is still controversial. But what we do as a pathologist have to record is the distance of the tumor from these surfaces, and label these surfaces, and document the distance. And if the tumor is reaching within 1 millimeter, that is regarded as a positive margin. And the third thing I want to say is that grossing need not be necessarily in a fixed manner. You have to achieve the goals of grossing. You should be able to give a complete report with all the core items. It is not necessary or mandatory to gross in a certain way only. For instance, in pancreas, some of the people may bivalve the pancreas and use slicing of the pancreas along the CBD and the pancreatic duct, or they can use axial slicing, which is both have their advantages and disadvantages. If you do a bivalving, you can see the ductal anatomy better, and you can identify, especially in cystic lesions, whether they are connected to the main ductal system or not. And whereas on the other hand, we have the axial slicing system, which Rajiv just mentioned, and that gives us an advantage in assessing the circumferential dissection margins and more thorough evaluation of the tumor, especially for cancers. That is recommended. And regarding the pancreatic lymph nodes, many times in the primary, because there is very little fat associated with this specimen, you may not be able to see grossly enlarged, unless the nodes are grossly enlarged, you may not be able to dissect too many nodes. So we should always try to go back to the specimen. Minimum for HSCC staging, TNM staging, 16 lymph nodes are required, but we should try and sample as many as possible. And after all your sampling of the lymph nodes is done, what we can do is we can use an orange peel kind of a technique where we can just shave off the entire pancreatic surfaces, which will, because most of the lymph nodes are embedded just underneath the compressed pancreatic surface and around the bile duct area. So a more thorough sampling can be done after the surfaces are already sampled. And we should never forget that now we also get portal vein resections or superior mesenteric vein resections. So sometimes they are just a segment of the vein wall which is attached on the SMV surface. So we have to specifically look for it, and especially when sometimes like our surgeons forget to mention that very important information, then we may miss that there is a small segment of a wall of the vein which is involved. So if a vein is involved, vein is part of the resection, then we should sample that and document whether vein involvement is there or not, and take the proximal and the inferior vein cut margins as well. So I would not take more time. I think Rajiv, you've done a fantastic job. And if there are any questions, we can open this for questions. I would like to invite the moderators back.
Yes, Dr. Manita, thank you, Dr. Rajiv, and you as well. So there are a few questions. Many of them I think you already covered in your class and your summary of the topic. Few questions are, Dr. Anita Borges asks, what is subserosal adipose tissue vis-a-vis pericolic adipose tissue? And what is the significance for staging of invasion of the subserosal adipose tissue? Any one of you can tell, Dr. Rajiv.
So there are two things. Is it a subserosal or pericolic adipose tissue? So subserosal as pericolic adipose tissue we usually use, especially for rectal tumors when there is no that's the overlying covering. Both as per stage, if it is restricted to the subserosa or in the pericolic fat, it is regarded as the T3. And but the evaluation of the, as I mentioned in my talk also, so if the tumor is reaching up to the subserosal fat, you have to examine and evaluate the overlying serosa very carefully distinguish whether it is a T3 versus a T4 tumor.
Then Dr. Sagarika Sarkar asks, what additional section should we submit to report tumor budding?
So, tumor budding is a new diagnostic criteria which we have to include now in the reporting of colorectal tumors. And what does tumor bud means? Either there is a discrete discohesive cells or a cluster of 4 cells which are invading into the surrounding tissue. So they are standards to be done on the evaluated on the standard section, but attempt should be made to include the peripheral normal tissue so that we can comment definitely on the actual budding or infiltration of the tumor into the surrounding structure. So section should not be only from the core or the center of the tumor, but definitely include the surrounding normal tissue.
Okay, sir. And another question regarding grossing is how many polyps should we submit in a FAP specimen?
Although there is no minimum cutoff, but all those polyps which are larger in size, even if they are more than 4 centimeters, they should be definitely be sampled. If the polyps which are showing overlying ulcerations, those are definitely need to be sampled. But as such minimum cutoffs are not there, but there should be selective sampling of those polyps which are likely to show more chances of transformation into the carcinoma.
Okay, sir. Dr. Munita, would you like to add anything regarding the questions?
So I agree basically that all suspicious looking and larger polyps, they should be sampled. There is no cutoff, but more than 1 centimeter, indurated, larger and villous polyps, they should be submitted. So extensive inspection should be done. All suspicious looking polyps should be, especially the larger ones, more than 2 centimeters, all of them should be. And there's no cutoff for size, but larger polyps, villous polyps, and all those which have indurated base, they should be submitted. Okay. Regarding tumor budding, I agree with Rajiv. It has to be assessed with the tumor stromal interface. So no additional sections are required, only that the tumor should be adequately sampled, and more towards the interface should be included. So as of now, tumor budding is not a core data item, but it is highly recommended to be reported. It's prognostic, adverse prognostic factor in colorectal cancers, and its reporting has to be with the ITBC criteria. There's a international tumor budding consensus conference which gives what objective to be used, what microscope your objective should be, the dimensions of the objective should be there, and how do you score it. So those consensus criteria should be used.
So it has mainly relevance, especially if there is tumors are restricted, early stage tumors, and if there are no other adverse factors are present, like lymph nodes, metastasis or LVI. So any other adverse histological factors, if they are not absent, in those scenarios, the role of tumor budding is more relevant.
And in polyps as well. In polyps as well. Where there is malignancy in the polyps, tumor budding should be reported.
And Dr. Nandini Ramachandani asks, how do you differentiate between tumor deposit and invasion in a post-neoadjuvant case?
So tumor deposits are basically tumor deposits are basically in the subserosal fat or the perirectal fat. That is where you basically want to distinguish it from a lymph node or a vascular, perivascular or a vascular embolus or from a perineural deposit. So as far as the post-therapy is concerned, there are chances of irregular shrinkage of the tumor. So within the tumor bed, we are basically not trying to distinguish and call it a tumor deposit, but it is in the lymph nodal basin where on the subserosal or the perirectal fat, where we try to see whether this is a lymph node metastasis. When we cannot determine, we don't see any lymph node tissue or a perivascular or a vessel vein wall or a perineural or a nerve associated with it, we call it a tumor deposit. So more of relevance is in trying to just categorizing it into a perineural deposit, a venous embolus, or a tumor deposit vis-a-vis lymph node metastasis, rather than in an area of tumor within the muscularis mucosa or within the submucosa or the muscularis propria, where we would not. So in some of the cases, we won't be able to say whether it is a tumor deposit or a residual tumor. So in post-therapy, it's not so relevant, but tumor deposits are relevant when you don't find any node metastasis, but you find tumor deposits. Then you want to give it a benefit of doubt and put it into a nodal rather than the T staging. So that is in a scenario where the nodes are negative and you find tumor deposits in the subserosal or in the perirectal fat. So that those.
Okay, sir. So I think those were almost all the questions which we have answered. So Dr. Sumit, would you like to come?
I would like to invite Dr. Borges for her expert comments. I'm waiting for her inch.
Thanks, Rajiv and Munita. I think Anita has left. Actually, she left a few minutes back. But I think you covered comprehensively, Rajiv and Munita, both of you. And then there's so many questions now. Even at 9, we passed 9, and we still have 500 plus people, waiting to listen to you more. You have anything last to say, Rajiv and Munita? You want to give any final comment before we call it off? And then back to Kumar Joshi after.
Just brief comment mainly for the resident. So before you start jump into the grossing of any specimen, just go to it, read the protocols and see whether your grossing is able to give you a proper evaluation of TNM staging at the end or not.
And I would like to just add that there are a lot of protocols and guidelines which are available, freely available. College of American Pathologists grossing protocol and reporting protocol is available. RCPAT protocol is available. And TMH also has a grossing book which details the various grossing protocols. So these should be read and grossing should be enjoyed. Once you know what you're supposed to do, you will enjoy it.
On that note,
advertising it. You just sorry.
Yes, sir. Go on.
No, as I said, Munita is advertising Tata Hospital books, so there is a conflict here.
Okay. So thank you for attending.
These are available. These are data sets which are available free in the public domain.
Okay, sir. So thank you everyone for attending the webinar. We hope you enjoyed it. Our next webinar is going to be on Tuesday, that is 25th next week. It is by Dr. Mufaddal Munim, and the topic is head and neck thyroid cytology case seminar. So scan the QR code if you want to join the Telegram group. There are a lot of updates there, and if you want to join and do share. I hope you have given the feedback for today's session. Thank you and see you next week.
Thank you. Bye-bye.
Thank you, sir.
Thank you, Rajiv. Thank you, Munita.
नहीं, हम साथ में देख रहे हैं ना। मैंने कल रात आपके लिए बंद कर दिया था क्योंकि आप सो गए थे।
Then going to
Yeah.
मुझे अभी क्या याद आएगा मैं तुम लोगों में अच्छा नहीं है अब नाम मत ब्रश करके आ रही थी